Welcome, everyone. Thanks for joining today. This is Blooducation Baristas podcast, where we're serving you piping hot transfusion conversations. And today, I'm so excited to welcome a really special guest today, Dr. Arturo Casadevall, who is going to talk about a very important topic, and that's convalescent plasma. And we're gonna talk through the new FDA guidance that has actually been just released to us that will allow us now to formally be able to apply for a biological license application, and this has become now something that blood centers can formally do. And I'm excited to talk to Dr. Casadevall to understand a little bit about the history of convalescent plasma, his personal journey of how he got involved in this area of medicine. And we can even get into some topics about, how quickly science moves and how some of our understanding of science takes place, which is a great conversation to have right now. So I'm excited now to welcome my friend and colleague. Thank you so much, Arturo, for being with us today.
Thank you for having me, Daniela. I look forward to chatting.
Yeah. So I have a very special place in my heart for infectious disease physicians, which is what you are. My father was an infectious disease doc. And the reason why I ended up being born in Florida is because he did his fellowship at the University of Miami. And then a few years later, met my mom, and then hello, here I am. And so I was raised in an infectious disease physician home. And interestingly, I do have a love for microbiology, virology, parasitology, and have brought that into my world as a pathologist. Probably had something to do with why I chose the field I did. But I'd love to learn more about how you kind of got into this profession and how it drew you into infectious disease and then into the research that you do in cryptococcus and other parasites and other things like that, other fungi. I know you love fungi.
Danielle, if you grow up in an infectious disease home, I bet you grew up with the worst stories of anything that could happen. Because ID doctors never get called when things go right. They only get called when things go wrong. So you end up witnessing all the things that can go wrong in all the specialties of medicine. And so you see the mosquito bite that turned into cellulitis. Not all the mosquito bites that got better. And it kind of, in so many ways, really shapes your feeling for risk.
I think that's a truism. I think what I saw maybe more than the next kid of a doctor was the books that my father had and his study materials had the most disgusting pictures. Because they were of, people with infectious diseases that probably and so I think as a child I was like, but something about my dad, though, is being in Miami and in the South Florida area, he was one of the first HIV physicians of that time. So I did get to see that era of medicine and understand it unfold. And what's fascinating is I kind of related to what happened with COVID, which was there was a lot of unknowns. And I remember my father being in a place of unknown, but I looked up to him as a hero, like he's going into the hospitals and helping these individuals when they don't really understand the infectious or pathogenesis.
Yeah, I mean, the field of infectious disease is the only field of medicine where I can say things have gotten worse since I trained. If you think about it, things have gotten better in oncology, things have gotten much better in transfusion medicine, and things like that. But the field of infectious disease is the only field of medicine that has to routinely deal with new diseases that we haven't seen before, and where the drugs that used to work often don't work anymore. Think about it, aspirin works as well today as when it was first introduced. But penicillin was developed used to work against many types of bacteria, and now it's just useless against most of the things we deal with.
That is interesting to think about. Um, but just recently during COVID, I think we saw something pretty incredible. That was that rapid
We,
implementation.
we're having a little bit of internet
It,
problems,
you know,
but
just recently we saw that rapid. Yeah, sorry, thank you. We just saw that rapid implementation of convalescent plasma. Now, on one hand, I'm not sure you would call that a new innovation, but we did see an incredible effort to get something done very quickly in a way that maybe never had been done before. And you might even say that with the vaccine as well.
that's right. I mean, the COVID pandemic show what is possible. Vaccines developed within a year, monoclonal antibodies, antivirals. But the thing that was there first was convalescent plasma. Convalescent plasma is available immediately once you have survivors in any sort of epidemic. And in the case of COVID, and in the past, it had always been used emergently. Daniela, there's an outbreak, so people use it, and then it passes, and there was never really time or to do the right studies. And one of the great legacies of the COVID pandemic, apart from being able to respond so quickly in many ways, is that we learn how to use it. And when we deal with the next pandemic, you can be sure that it will be, or the next big outbreak, that it will be deployed all over again. But hopefully, we have now learned how to use it, and it will be used correctly from day one, and it's going to save even more lives than it saved back in 2020.
A few years ago, I was a little bit reluctant to think about some of these topics of disaster preparation. For instance, when I learned that my kids were having an intruder alert simulation, I was like, oh, I rolled my eyes. But I know that we're in this place where we have to be responsible. So when you said the next pandemic, my heart dropped a little bit, but there's a reality there. So how do we use the lessons we learned? And is there something that we should be considering that is on the horizon? Is there something now, not just an if, but is there something we should begin preparing for?
Yes, I mean, the thing that we were all watching very carefully, and we have to be very thankful that it has not happened, has been the world in the midst of a bird flu epidemic. That's H5N1, which has a very high mortality. It began on the birds, it spread throughout the birds, it's killed millions and millions of birds. Then it got into some mammals. And as you may have heard, it's gotten into the cows in the United States. And some people who take care of cows have gotten infected. But the infections have been like conjunctivitis. And the what we worry about is that this moves to aerosol spread. That is, that people get pneumonia, that we get aerosol, because then we would have another, I hate to say it, another pandemic.
Well, I remember learning early on in medical school the types of different mutations that can occur with flu, and you have the different antigenic mutations that can occur. But really, how realistic can it happen where we have a major shift where it goes from conjunctivitis to aerosolized spread? Is that really a
Yeah, it's all. I use the fancy word as stochastic, which means it's chance.
okay?
Every time a human gets infected, you roll the dice,
Okay.
and it can happen. It can, and we have been very lucky up to now because it hasn't happened. But if it was to happen, it could potentially be far more disruptive than COVID, primarily because the mortality may be higher. And one of the things, despite how disruptive COVID was, the lights stayed on and there was food in the supermarkets. And the big concern with a pandemic is that after you get to a certain amount of mortality, society doesn't work anymore. Police doesn't come to work, trucks don't run, and then you basically have social disturbances, and that's when you have even greater mortality. But I don't want to scare anybody off. People are watching it. Hopefully, we learn from COVID and we will be able to mobilize rapidly.
Mm-hmm. Well, thank you for sharing that. And yeah, I think we have definitely hemovigilance teams and organizations that are keeping their finger on the pulse of this, including yourself and others, TTD, transfusion transmitted diseases of the AVB working group. So I know that we are watching these things carefully. Well, maybe we could go back to convalescent plasma. And I know that you have a tremendous history there. Just talking about how did you get affiliated with working within this area of which is it's kind of our bridge between microbiology and transfusion medicine.
Medicine, that's right. So I'm a student of history. I really like about history, to learn about it. And I knew that convalescent plasma had essentially been rolled out. It was called serum before people know how to make plasma. They used to use serum so in 1918, for example, when there was people didn't even know what was killing them. In the army camps where they struck, they mobilized, and they simply would take serum from soldiers who recovered and give it to soldiers who were getting sick. And they were able to reduce the mortality by about 20%. And this was documented at the time, and it was written about. And so I knew that was happening. And in January of 2020, once I began to hear noises about asymptomatic transmission, I knew that this was, as an infectious disease doctor, I knew that this was not containable. Because the reason we were able to contain the 2003 SARS outbreak was because it didn't become communicable till people became symptomatic. But if you now have people spreading it and don't even know that they're spreading it, that is the recipe for a pandemic. And what was happening was I was listening to the news. I was trying to get as much information as I could. And people were talking about how to rush to make vaccines, how to rush to make antivirals, how to make monoclonal antibodies. And no one was talking about convalescent plasma. And the question I posed to you, Daniela, is how would you get the word out? And I'm a journal editor. I could have put something in one of the medical journals, but that was not going to do it. You really need something to reach out to the general public. So I wrote an op-ed and I sent it to the New York Times. They didn't want it. I sent it to the Washington Post. They didn't want it. I sent it to Bloomberg News. They didn't want it. And then, like everything in life, I sent it to the right place at the right time. I sent it to the Wall Street Journal on the day that the market tanked. And because the market had tanked, I think they look at this as this is potential good news. And they printed it right away. And for me, the important thing was that I now had a beautifully written, because they rewrite everything for you, a beautifully written op-ed that I could just send the link out. And I began sending it to all my friends. It was published on February 28th, 2020. By 3 days later, we were organizing at Hopkins. There was a tremendous amount of activity at the time. And this is what I call a credit to the community. Mm. The first patient was treated in March 28th. Think about that. We went from basically watching the pandemic in the rest of the world to treating the first patient in the United States. At the end of the month, it was treated in Texas. And then convalescent plasma was the only therapy for many, many months. And we can talk about that enormous effort, but the blood banking community, talking about mobilization, went from producing 0 units to producing tens of thousands of units a month by the fall, such that there was no shortage by the fall. And 40% of all the patients in October of 2020 were treated with convalescent plasma.
I actually remember when that article was published in the Wall Street Journal. And because a month ago, we had an infectious disease fellow in January actually talk to the Department of Pathology about this virus that's coming out of China, right? And so I was following it, and I want to admit something to you. I didn't really even understand what the word convalescent meant until I really didn't.
We don't use it. We don't use the word convalescent anymore.
Yeah, so I had to really understand even that concept. So it meant that when a person starts developing an antibody response to the infectious agent. So I was like, oh, okay. But and it was amazing because there was such a feeling of dread, Arturo. I don't know if you remember, but we felt like there was nothing to provide patients and each other, nothing. And then there was this hope. There was this light that shone. And I remember because I was still on the hospital side. I was the medical director at that time of a St. Louis University hospital, but working really closely with the blood center. And we started to recruit individuals, and we would call them COVID angels.
COVID. Oh, that's wonderful. I'm going to remember that. COVID angels. But
yeah.
The word convalescent is not used in our language. And what does convalescent means? You could have said get well plasma or recovering plasma or something like that.
Yes. Recovering plasma would have been better on the public. And even as a transfusion, I was very short from graduating fellowship and being a very new, wet junior physician, and quickly went into a medical director role. But yes, as we have to learn how to speak to the public, on all levels, we have to be considering the vernacular, and the vocabulary that we use. Because even myself, I'm a board certified, I didn't know what convalescent really meant.
Yeah, it's the remarkable thing about it was that it was used right away. And, we have a comment on the chat about the use of convalescent plasma during the Ebola outbreak. And it was also another example where things are used emergently. And in fact, when it was first deployed in the United States, there were no tests for antibody. People basically said, well, if the person recovered, they have some chance of having antibodies. So the early units that were used, we didn't really know even what was in there. The antibody tests don't become available and remarkably within a couple of months. But by the summer, one can test convalescent plasma for antibody content. And the product just gets better and better and better. Because at the beginning, you just take it on history. Well, did you have COVID? Yeah. Well, 2 weeks later, you can donate. Well, now you can sort it out. And by the summer, the FDA had provided guidance on what was a unit of convalescent defined by titer. And it's remarkable, Daniela, when you think how rapid things happen. Rapid things happen.
I do want to just take a minute again to applaud the blood centers and working closely with hospitals, but it truly was blood centers. I know, and I wasn't there, it was under the leadership of Dr. Lou Katz, but it was a team effort. I believe that they were able to implement in 10 days, which is extraordinary to be able to do something like that. So you use the word mobilization, and I think that it was applauded, but just again, to take a moment, almost to stand up, rise and clap for these blood centers to do it. And these individuals are also going through the COVID pandemic. So it's a lot going on, but
it happened emergent. In other words, there was no government directing the effort. Communities got together. Community groups began to get donating. The fight is in us. All that thing happened, and if you think about it, it's something that to celebrate and what was a very dark time.
Yes, you're right. But I remember as it began to be rolled out. Now remember, I'm on the hospital side. I was very confused about the dosing. And I held up a plan, and I'm like, and I realized that you've got, so many different types of donors. And again, you're saying, we don't really even have a way to test exactly the donor. We did develop that with time, but what's a dose of convalescent CCP? And I remember asking my friend in New York, who was a fellow, we were both sort of like in the same, place, which, to tell you the truth, it didn't matter if you were fellow or 30 years senior. We were all at the same level of knowledge and information. There was sort of like a flattening that happens. And so
we're dealing with something new.
Totally new. And so I was just like, well, how are you dosing this? And who gets what? And when do they get it? And when's the best time? And that might help us to think about some of the work that you write about. And I love that, you talk about fragile science. And I think that this is a great topic to kind of pivot there, which is just about how do we produce really good scientific output so that we can do it in a way that we can follow and adhere to, and also build public trust. Glitching again.
So before we go there, maybe to wrap up the convalescent plasma story, because it ties in with the issue of how do we know what we know, which is really when you are holding up the bag and said, well, how do we know what's in here and how do we use it? Yes. So the United States did things very differently than the rest of the world. The United States, through the FDA, and here the FDA gets the lion's share of the credit, allowed the American public to get plasma through largely historical evidence that it worked. There was nothing available. Set up a registry, and 90,000 units were given. And by the summer, we knew what was in a unit, and we knew that if you gave a certain titer, it was associated with reduced mortality. The rest of the world didn't do that. The rest of the world said, okay, you want to use convalescent plasma, you have to do a clinical trial. You have to show me that it works. And here was a huge problem because people didn't even know what dosing, when to use it, when to give it. And many of the clinical trials were set up and in conditions when they could not possibly work. For example, the recovery trial in the UK, the largest one, very influential, treated patients that were actually very sick at that point, often many, many days into the hospital. And the net result was that they couldn't show a difference in mortality. And when they couldn't show a difference in mortality, the conclusion was, well, it didn't work. No, they couldn't show a difference in mortality because the trial tested convalescent plasma in conditions when it could not work.
Right.
And that will have enormous repercussions. By then, though, we had all our alternatives here in the United States. But at Hopkins, we knew that you needed to treat early. And Hopkins, from the very beginning, set up an outpatient trial. So people who were at risk of progressing, who were sick, get treated. And if you treat them, in the first 5 days, the efficacy of convalescent plasma was as good as monoclonal antibodies. You reduce the likelihood of progression to hospitalization by 80 to 90%. But that decision made by the FDA, we now have documented that it saved tens of thousands of lives. That paper is available as in bioarchive. If people want to look at it, it's in review, and we hope it will come out this year. And that paper is it's a celebration of what was done by so many people, from donors to blood bankers to people who learn how to use this essentially on the fly. And on the other hand, we also do the calculations. What could have been done had we knew what we know today?
Right.
And then the number of lives saved goes into the hundreds of thousands.
Right.
If we had only known, that you needed to set up outpatient infrastructure, that you could have kept those people from those 10 cities, 10 hospitals in Central Park. Remember when there were no beds in New York City? All that. But I think the important lesson is that we know for the next pandemic, and when it happens, it will be rolled out again. And everybody who's hearing, the rules are simple: high titer, give it early. This is an antiviral. This is not going to work once people have lung inflammation and given to the unit. There is no mechanism by which antibody reverses inflammation.
Those are two great rules. High titer, give it early.
Yeah,
And that, I mean, early on, I was a young physician coming in, and that made sense to me. You know, let's give this earlier. Now let's not give it to a patient who's already in the ICU where we're seeing this coagulopathy taking place.
That's right.
You know, give it
I mean, in
earlier.
retrospect, that we used those units when people were getting sick at home.
Yeah.
And those who are likely to progress, which we knew by April, it was people with heart disease, lung disease, hypertension, take the elderly and give them a unit at that time. It would have made a tremendous difference on it. But you know what? I think that if we face bird flu, hopefully we would do that the next time around.
Could you explain then the evolution from convalescent plasma to monoclonal antibodies? And what your thoughts are in
monoclonal antibodies, you know, I spent my entire life working on monoclonals, and monoclonals are wonderful, but they have an Achilles heel. And the Achilles heel is that they bind to only a small part of the virus. And when you're dealing with a virus like SARS-CoV-2 that mutates very rapidly, then it was a prescription for disaster, that you're going to lose it. So all these great reagents are developed. They're introduced. They were used to treat President Reagan, remember? Not Reagan, President Trump, very early on when it was still investigational. And all of them get deployed, and they're wonderful. But guess what? Every single one that got deployed had to be withdrawn. And plasma is very different, because in plasma you have thousands of different antibodies. So it's very hard for the virus to get around plasma. Also, plasma is the only antibody therapy that keeps up with the variants. Because think about it, you get plasma from a couple of weeks ago, somebody who had a couple of weeks ago, what are you treating?
Right.
And the great paradox is that convalescent plasma was the first antibody therapy deployed against SARS-CoV-2. And it is today the only one standing.
Wow. That makes me think, you know, we have many forms of plasma, but in my mind, I like to think of it, you have ones that are frozen and ones that stay in the liquid form. Right. So maybe we should be thinking about in the future that really recovered plasma, convalescent plasma, recover. So maybe we should always be just using it in its liquid form, because that has a 26-day expiration. And that's really how quickly evolving the virus may be, that you want that donor population and the antibodies from that donor population versus ones that have a year of storage. That year might not be as effective, you know, the ones that were collected maybe 6-9 a year ago, 12 months ago.
Daniela, a remarkable thing that came out from that initial registry study is that the Mayo Clinic colleagues, since they knew where every unit had been collected, and they knew where it had been used, and they knew what happened to the patient, they were able to show that convalescent plasma loses activity with geographic distance.
Oh, wow.
So if you go over 150 miles, the incidence, the efficacy drop, and that is because different cities have different strains of the virus.
Wow. Yeah.
So what you really want to do, this is another product. You want early, you want high titer, and local if possible.
Right. Give local.
It's local if possible. Yeah. And you know, another paradox with the clinical trials was because they wanted to centralize plasma so that they could control the units. They often set up national distribution things. And the net result is that they didn't know about this 150 miles, and they were shipping plasma across the country. And, you know, if you're in New York, you want New York plasma. You don't necessarily want LA plasma. Yeah,
that's really interesting. What about the use of it today? You know, it's almost like we don't even personally, I'm not asked about it.
Yeah.
So it was interesting. It came back up again when we have this new FDA guidance. I do want to talk to you about, you know, because it's the recommendations for submission. So some of the things is establishing donor eligibility. establishing, the qualifications, the indications for use. And it's interesting, that's on the blood center to have to be able to document. I could really use some help in figuring that out.
Well, yes, these documents are quite complicated. Today we're having the planned conference call, and we're going to discuss some issues related to it. But getting back to your question,
Arturo, can you tell us what the plan is for those of us?
Plan is a group that came out of the pandemic working on convalescent plasma, and the realization was that the AABB. By the way, don't ask me to tell you what PLAN means because I don't remember. Just think plan equals convalescent plasma for the past, present, and future. Okay. The AAB convened this group that continues to meet monthly, and we discussed a lot of these issues. And in part, we've been discussing bird flu. We've been discussing the possibility of using it in other situations. But what's happened with convalescent plasma is fascinating, and this is why your podcast is so important. And so it depends. It's been used in some institutions and it's not being used in others. Why? Because it depends on the physicians, how much they know about it.
Right.
But so today, there is no need for convalescent plasma for the 99% of the population. We all have antibody, either from the vaccine or from getting COVID. But the immunosuppressed don't. And when they get COVID, they often can't clear it. And that interferes with other forms of therapy. For example, if one is getting therapy for cancers, one is getting transplants and things like that. So at Hopkins, we continue to use convalescent plasma, and it varies with the incidence of COVID in the community. Like to give you an example, in the month of January, 30 units were used.
Mm-hmm, mm-hmm.
And that almost all went straight into individuals who were immunosuppressed, B-cell deficient. And then it dropped. In June, 1 unit was used. And there are suppliers. People can reach out to Bill Block. He can connect you with who has it, who's collecting it. But generally, if the medical centers are using it and know how to use it, it is one of the options available for treating what is called chronic COVID, this situation in which in immunosuppressed patients, you often can't get rid of it, even when you put multiple courses of remdesivir. The combination of antivirals together with high titer convalescent plasma is producing excellent results. Mayo Clinic continues to use it. They collect their own plasma out there, right. And they have had excellent results keeping people out of the hospital. Primarily, you have people with early COVID, immunosuppressed, likely to progress, treat them with plasma, and the likelihood that they get admitted just drops tremendously.
So I heard you mention that it should be treated in patients that are immunosuppressed or on immunosuppressive medications to treat either early COVID or to treat chronic COVID, where it seems like they cannot recover from the disease. When we think about the donors that are being collected, it is my understanding that 85% of the American population has been vaccinated. And even with a full dose, so from that first full dose of vaccination, and that it is most likely that if a donor is tested today, they would actually have antibodies. I'm not sure what's considered high titer, but what would you consider high titer, and what does a dose look like for you in terms of a unit?
So what is worthwhile thinking about the situation 4 years ago. 4 years ago, the only people who had antibody to COVID were people who have had it. But what we learned in the last couple of years is that people who have been vaccinated and then get COVID, or vice versa, had COVID and then get vaccinated, made tremendous antibody responses.
Right.
And to put that in perspective, a unit of today has about anywhere from 100 to 1,000 fold more antibody than it did 4 years ago. So most of the units that you're handling, your FFP, is full of antibody because the
Okay.
American population has so much antibody on board.
Right.
So the paradox is that back then we wanted to get high titer units, and few people mounted really good antibody responses. Today,
Right.
the country is awash with high antibody units. So the issue is to qualify them by the EUA, which, as you know, remains in force. The FDA recognizes that this is a critical therapy for many of the immunosuppressed and is maintaining the EUA even though the emergency ended. And the reason they put out the guidance to industry is because they want this license so they can essentially move off an EUA. And I think that, it's likely to evolve. I mean, the key is that the very high titer units are coming from people who had both COVID and the vaccine. And those are completely different, almost a completely different product from what was available back in 2020.
Yeah, I remember we talked about COVID angels. So I remember in the beginning how infectious disease doctors were trying to target individuals that were hospitalized to donate, not just the asymptomatic or people who were tested positive, but really try to target those that were probably very sick because they would even have a very high titer. Some of that had to be worked out, even that understanding of even if you were asymptomatic, what was your antibody titer. It's very interesting to even look.
Daniela, this was how humbling it was, because I remember people saying, well, if they stayed out of the hospital, they must have made a great antibody response. Little do we know that was the opposite. The people who made the best antibody response were the ones who got really sick. So it turned out that the paradox was that the sicker you got, the higher the antibody response you made. But those people often couldn't donate right away because they had to recover going home.
That's right. I remember that.
We were caught into this, you would think, right? Well, they stayed out of the hospital, they must be really good. No, and that was a major realization that, this disease was different, that we were dealing with something very different. The other thing to remember in those days was there was all this fear or this phenomenon of antibody-dependent enhancement. This was the idea that some antibodies may, in fact, drive the infection forward. And in the early days, there was a lot of concern. Well, you're going to give them a unit of blood, plasma, you may make it worse. But by April, the registry that was set up that everybody had to provide information to had shown that this stuff was very safe.
I think that there was this other concern, if I remember correctly, that it actually can induce antigenic change. Like the actual plasma itself, that was a very challenging thing for me to wrap my head around.
Yeah, but it was made up because there was never any evidence for it. It was somewhat. You got to understand, for reasons that I don't understand, some fraction of the population of physicians always hated plasma.
Okay.
And I think part of the reason for that is because they look, like one said to me, when I hang a unit of plasma, I don't know what's in it.
Yeah.
Whereas if you hang a monoclonal antibody, if you hang a drug, you know what's in it. And that mindset that I don't know what a titer is. What is a titer? What does it mean? How much am I giving? Was very almost went against the grain of modern medicine.
But Arturo, I can't help physicians because I myself, I struggle with it as well. I mean, I joke around even what's a dose of a red cell unit and how are we? So definitely. And then what's amazing is when you learn, when you're training and you're learning what a unit of plasma is, well, what's in plasma? What's the reason we're giving plasma? Oh, well, the reason is to correct vitamin K deficiency. Or the reason is to give back Adam's TS13 for TTP. Right. Or the reason is, because it has antiglobulin in it. There's a lot in plasma.
There's a lot in plasma.
And we kind of silo what we want it to be for the disease. Yes. we silo for what it is based on the disease we want to treat, but it's got a lot of stuff in the bag. So I understand a physician's unease, because it is, first of all, it's the only drug we have where the donor is different, right? Every time, even the same donor can have a different day, and what in the bag is not standardized.
That's right. Every unit is different, and this was very, very hard for some physicians to deal with. And I remember going to meetings, constant, Zoom meetings. One of the people would raise these questions. Well, but the bottom line is the answer is no. There were a couple of case reports in which immunosuppressed individuals with a lot of virus that could not clear, as you gave them more and more units, they appeared to develop resistance to some of those. But those were in the fingers of your hand, those cases. And the paradox is that it was the monoclonals where the problem arose.
Right.
It was the monoclonals that in fact selected for resistance. And we have published data, and I emphasize to the audience, this is suggestive. This is by no means at all proven. But there is a suggestion in the data that when you introduce the monoclonal, and it's selected for resistance, the resistance spread on the population. Think about it. You're giving it to immunosuppressed patient. The immunosuppressed patient can give it to their caretaker. And now that antibody, that virus is a little different because it was made from a monoclonal. It's resistant to a monoclonal. And we think that there is a possibility, emphasized possibility, that this could have the introduction of monoclonals as single agents in the immunosuppressed could have basically gave us some of the variants.
That's interesting. Yeah, that it was actually the monoclonal agents that may have been
exactly. And yet those are the ones in which you could say, I'm giving the patient exactly 500 milligrams.
Right. That's so.
I know what I'm hanging.
Right. Yeah. Well, I think though that it kind of allows us to get into the subject though of that fragility in medicine topic that I really enjoy that you write about, and that balance of providing evidence-based, very, very secure and very, how would you say it, substantial, research that, because the one thing that I faced the most in the last few years is I have just witnessed a complete lack of confidence and trust in the public eyes as a physician. I'm going to go back to the beginning. When my father was a physician, doctors, what they said, people believed, and they looked up to them and they trusted them. And now I don't feel that same amount of trust and from the public eye, and I just wanted to say, and maybe you could comment on this, something that I've had to, I've been challenged with, and it's been very eye-opening to me, are individuals who don't want to receive blood from those who have received the COVID-19 vaccine. And, I think that it does fall into the same type of topic we're talking about, but maybe you could share with us your thoughts about this area of the fragility of medicine.
I comment more, it's almost the fragility of science. So we live in a world think about the technology that we're using to communicate. Think about science, technology is everywhere. And we tend to think, it's often going too fast. The changes are just enormous. What we have even seen in our lives. But I think people don't realize, so when you go and you look at history, that things can be lost and forgotten. Go to the Roman ruins when you get a chance to go to Europe. Look at the arches. The technology for that was forgotten with the collapse of the Roman Empire. It had to be rediscovered. So this idea that we have made all this progress and that this will always remain with us, it's not really supported by the history of humanity. So science is fragile. It is dependent on its society. It's dependent on the society to train future scientists, to support it, and to trust it in many ways. And that trust and that fragility is, to me, very worrisome because us, humanity, is facing probably some of the greatest dangers in the years ahead. Climate change, the failing green revolution. We've been through a pandemic with a 1% mortality. Give us 5 to 10% mortality, and society will stop functioning. A rock from outer space. So the insurance policy, science is the best insurance policy. We got to keep working. We need to maintain this enterprise because it's the most, it's the gives us the best chance that we're gonna basically make it as a species. And yet it's very fragile. And yet you saw the COVID pandemic. I think science, medicine took a tremendous hit. The trust has gone down. And I think it behooves us to try to understand what went wrong. Can we get it back? And my own experience, and I think we share in this program, is that we did not know very much about it in the early days, and yet we had to operate with the knowledge that we had. So the public wants answers, and they want definitive answers. And initially, for example, people said, well, there's no need for masks. You get it by touching. Remember, don't touch, wash your hands 4 or 5 times.
Everything.
Right. And then after a while says, then, well, it's masks. And then, a study may be published that masks don't work. And what the problem essentially is that in science works on knowledge. It's always provisional. We take pride on the fact that what we know today, we will overturn tomorrow. But the public wants answers. And they want you to tell them, will the mask work, yes or no? And what we should have said is, you know what, we don't know, but it stands to reason that if it stops some droplets from going around, it may help. And that is, I think, that going forward, if we get ourselves into another public health emergency, I think everybody goes on TV, everybody who speaks should begin to say, based on what we know, and this may change, but today, this is the best advice I can give you. And that is something that wasn't done. So
it sounds like we have to be a little bit more humble and honest with the public and good at saying, we don't know, but with the knowledge we have at hand, which may change tomorrow, this is what we believe is the thing that we should be doing.
Right. And I think that if every conversation had began that way, we may be in a different place. Because my great concern, Daniela, is that we began this program talking about bird flu. I'm worried that despite all the progress we made, that if the public is not with the health authorities, that the situation may be much worse the next time around.
Well, please God that, if this does happen, we will be prepared and we'll be more united and think about the things that we've learned from the last few years. Because in addition to the operational lessons we learned, we can't go backwards. Also, in the public trust, we all have to work together in cohesion, in solidarity. I don't think we could take any more divisiveness. That's for sure.
No, but it's also, people need to realize that good meaning people, that there has always been in every generation some pushback against knowledge. For example, Ben Franklin was against vaccination and for smallpox.
Okay.
He was a very active against vaccination. He lost his daughter to smallpox, and then he regretted that kind of thing. So what if you think that concerns about vaccines, that anti-vax movements were there in revolutionary times?
Yes.
that this is part of humanity. This is something that public health authorities need to always consider, and we need to work at it. And
totally. I love that you bring that up, because the individuals that I do speak with, and I really do try to take the time to speak to, whether it's a donor or a donor's loved one or someone in the public, about their sentiments about not wanting to receive blood from a COVID vaccinated donor. I have to tell you that all of those individuals are coming from a place where they really just want to do the right thing. And this is what they think is the right thing. They want to protect themselves, and they want it to protect their loved ones. Now, when I have a further conversation with them about their understanding, I think that there are gaps in knowledge. But I learned that there may be gaps in my knowledge too.
There are definitely gaps in mine, but it's also the way our brain tends to work. If you go down a trail and you run into a snake,
right?
You may say, there's a trail down that snake, and inevitably, if you get a vaccine, other things will happen. Things happen in life.
Yes.
And when people make the association between the two, and our brains are great at making associations, they are not that great at the thinking to not make the association.
Right, exactly.
And therefore, I got that vaccine, and ever since I can't clear my throat. This is association for that person is very real.
Right.
But I think and to say, there is no association between the vaccine and problems with the throat requires a lot of study, and then you will get the epidemiological data and something like that. And it often may be in such a complex way that you can't even communicate it, or the person may not even accept it.
Mm-hmm. Well, this has been such a great conversation. I feel like I've grown from it. We have about 5 minutes left, and maybe if there are listeners on the podcast right now from LinkedIn or YouTube or X, feel free to put in your questions in the chat box. We're happy to take it. In the meantime, maybe I'll just turn to you, Arturo, and say, what did we miss in this conversation? We probably could talk another 5 hours, but what would you want to leave us with?
I want the community, and this community that involves a lot of people in the blood banking community, to recognize what a tremendous effort they did, and to think back at this time, a time of crisis, what was done and how many lives were saved, and that we need to think about blood banking as part of the societal's defense for the next pandemic. And that is a completely different way of thinking that we were thinking in 2019.
Wow, I think it is a wonderful thing to leave with, and think about us as a community and the communities that we serve, and all of the altruistic blood donors that gave at that time. And you're right, what it took to mobilize, like you said. Thank you for leaving us with that idea. So it doesn't look like we do have, it doesn't look like we have any questions, but feel free later to post anything. I want to thank you so much for joining me. I know you have a lot going on, and I hope we can meet again to talk about some other interesting topics in the future.
I'd be happy to join you again. Thank you, Daniela, for having me.
Thank you for all the work that you do in every the organizations, and all of the you do behind, and the teaching you do, and the research you do. So thank you from all of us.
Thank you both. Thank you.
Okay. Have a wonderful day and a great weekend. And thanks to everyone for listening today. Take care.
Bye-bye.